Thank you so much, Ryan. Thank you to Greg Jamian and AmeriCare for having me here. It's really an honor to be here. Can you guys hear me okay? All right. So I am pretty new to the TBI world. I actually just started working at Beaumont as medical director of TBI back in August here. I did do my residency at Royal Oak Beaumont, and then I did a year fellowship in traumatic brain injury at JFK Johnson Rehab Institute in Edison, New Jersey. Following completion of that, I came back to Beaumont Hospital, where now I'm just starting to get established in my practice there. So today I was going to talk to you a little bit about treatment of traumatic brain injury and care of traumatic brain injury patients, in addition to some new research that's been going on in the TBI field. All right, let's see if I can figure this out. Okay, so some goals and objectives, some things that I want you to gain an understanding of from this lecture today. Just a basic understanding of traumatic brain injury itself, some of the mechanisms of action behind this, and what's actually going on more at the cellular level. Be able to understand and describe common symptoms that patients have after traumatic brain injury. I know Dr. Mucky went over this a little bit in his lecture as well. And identify coexisting medical conditions that may be contributing to the traumatic brain injury or interfering in treatment related to this. Also want you to identify common treatments for traumatic brain injury, including rehabilitation, in addition to some pharmacologic management for certain conditions. I'd also like you to have some familiarity with new developments and research that has been going on in TBI. Let's see if I got this. Okay, so ROSE by any other name. There are many, many ways in which people will refer to traumatic brain injury. Concussion, which is usually referred to as mild brain injury, acquired brain injury, closed head injury, head injury. Here are all these terms thrown around, all fall under the category of traumatic brain injury. So definition, what is a traumatic brain injury? I know we just spent a lot of time talking about that. So this is from the Brain Injury Alliance. A traumatic brain injury is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. And something that I want to point out here is that you do not need to have a loss of consciousness to have a traumatic brain injury. And oftentimes I'll see notes or see documentation or patients coming into me saying, you know, this person didn't lose consciousness. There's no way they had a traumatic brain injury, and that's absolutely not true. So pathophysiology of traumatic brain injury, we talked about this a little already. Two different basic categories, primary injury and secondary injury. Primary injury is going to be what happened right at that moment in time, that initial insult, that direct disruption of brain parenchyma, direct contusions, focal ischemia, focal hemorrhages, your epidurals, subdurals, subarachnoid hemorrhages, and this term diffuse axonal injury. The secondary injury is all the things that happen after that point in time. So excitotoxicity, free radical production, a cytotoxic cascade, energy failure, which ultimately leads to apoptosis or cell death. All right, there's secondary things that can happen as well, including brain swelling and ischemia and multiple other medical problems that may contribute to development of basically subsequent injury after this initial insult. A lot of research is dedicated to how we prevent this secondary injury from happening. So TBI breakdown, as we talked about, usually divided into categories of mild, moderate, or severe. Sometimes you may see people label something as being very mild or very severe. Usually in these three main categories, and these are the main three categories that patients are divided into for most of the research that's out there in the TBI community. All right, this is based off scales that we talked about, the Glasgow Coma Scale, duration of post-traumatic amnesia, and a couple other criteria that we'll divide patients into. So this is something that my mentor at JFK would say in fellowship and when he went around and did lectures. Let's say, for example, you go to your doctor, and your doctor tells you you have cancer. Obviously, you're going to want to know, what kind of cancer do I have? What is the treatments for this cancer? Tell me more about it. And so let's say you go in to see your doctor and says, Miss Jones, you have mild cancer, or you have moderate cancer. And the research has shown that for mild cancer, I'm going to give you drug X and Y. That's been shown to be the best for you. If your physician said that to you, you'd probably get up and walk out that office door and go looking to find somebody else to treat you. And this isn't to say that the mild, moderate, and severe categories aren't good uses or good divisions for research, but there's definitely a lot more that needs to be done to divide brain injury into further categorization. Obviously, someone that has a penetrating frontal lobe injury may present very differently and may have very different symptoms than somebody who has a brainstem injury or diffuse axonal injury. But yet, these two patients may be lumped into that same category of severe. So, obviously, the brain is a very complex structure, as we talked about, and that is an area where a lot of research is being done, looking into how we can divide these categories up a little bit better. So rather than lumping apples and oranges together into one group and treating patients the same, we may be able to pull out those oranges or pull out those apples and establish treatments that work better for that particular individual. So when I see patients in the office or in the hospital, in the emergency department, I try and think of every traumatic brain injury as being unique, and I don't tend to focus as much on those mild, moderate, and severe categories. So prevention. Obviously, prevention for these injuries is key. Increased awareness about traumatic brain injury in recent years has been great, with the movie Concussion, with all of the research and interest in concussions, NFL football players, etc. It's great that people are aware of this, people are taking more of an interest in it, and trying to prevent these injuries from happening, in addition to preventing subsequent injuries from happening, as we know that further repetitive concussions are devastating. So research, let's look at just a couple of research studies that have been done on early intervention. This in events of trying to prevent some of that secondary injury, that cytotoxic cascade, that cell death that might occur after that initial insult. So this is an old study. This was back from 2004, but this was the CRASH trial, the corticosteroid randomization after significant head injury. And this was actually something that was routinely done before this study came out, that patients with traumatic brain injuries would be given steroids, with the idea that those steroids would help reduce inflammation and overall, you'd assume, would help brain function and improve survival. So this was actually a huge trial that was done with 20,000 patients. And they actually found that steroid administration increased the risk of death by 18% within 14 days of injury. So this was a major game-changing thing in the field of TBI, that we no longer give steroids to patients after head injury after this trial was done. A newer trial that came out, this was the PROTECT 3 trial. This actually came out in JAMA, was published in 2014. This study was around progesterone. It was theorized that progesterone, and in smaller studies, had been found to be protective after traumatic brain injury. So patients were randomized to receive either progesterone or placebo within 4 hours after sustaining a moderate to severe traumatic brain injury. They actually found that there was no benefit to the progesterone over placebo in patient outcomes. So we keep looking for the magic bullet, the magic drug. Haven't necessarily established what that is yet. So treatment for traumatic brain injury. Again, this is an extremely large and extremely complex topic. For the sake of this talk and the time that we have, I'm going to focus more on mild traumatic brain injury, more concussion-type symptoms that patients may present in. So mild traumatic brain injury, also known as concussion. Mild traumatic brain injury is actually the more preferred term, but oftentimes there's some stigma associated with that. If I asked the room, who here has had a mild traumatic brain injury? Is anyone? Who here has had a concussion? A couple of people are going to raise your hands. And so that reality that a concussion is a mild traumatic brain injury, but people are just less likely to recognize that or don't appreciate the severity of it necessarily. So there are over 1 million mild traumatic brain injuries that occur each year in the United States. And of note, loss of consciousness occurs in less than 10% of them. 85% of patients with these mild traumatic brain injury are actually going to get better on their own. Simple education, symptom management early on, and just reassurance of the patients is often enough for these patients to do okay, get back on with their normal lives. There are 15% or so that may have persistent symptoms even up to a year or beyond after their mild traumatic brain injury, and that's the population that we tend to need to intervene a little bit more with. Treatment, again, is tailored to each individual with importance placed on symptom management for the most part, as every patient is unique and every injury is unique, that they may present with different symptoms that need to be addressed in different ways. So As we talked about, symptoms following mild traumatic brain injury can be extensive, and this is the same is true with more moderate or severe injuries as well. The most common things that I see are frequently headaches and dizziness. People come in with this complaint all the time. People may be nauseous. They may feel dazed or confused. They may have difficulty with concentration, may feel like their memory is impaired. They may not be able to concentrate on things or notice that at work I'm forgetting things. I'm having problems, calling people back, phone numbers, names, things that I used to remember, and I just can't remember those things anymore. They may not be sleeping well at night. They may notice that they can't fall asleep. They can't stay asleep. Or maybe they're sleeping at weird times during the day, and that just wasn't the way that they were acting previously. They may notice problems with their fatigue, depression overall related to the injury itself, or related to everything else that's changed in their lives. That independence that they once had is now gone. Changes in the dynamics in their home situation. They're no longer the head of the household. Someone else maybe is providing assistance to them, and that's definitely something that can result in depression. They may have balance issues, also associated potentially with this dizziness. Visual changes, sensitivity to light, sensitivity to sound, hearing changes, ringing in their ears. All of these problems can present after a traumatic brain injury, and each one of them kind of have a different way to go about addressing. So when we're evaluating a patient in the office with a traumatic brain injury, you always want to take into account these premorbid factors. How was this person doing before their injury? What was their educational level? What kind of work did they do? What kind of person were they? What was their personality like? It's often helpful to have family members there to get a sense of what this person was like before this happened and how are they different now. Any other injuries that they may have sustained in the past, any chronic pain problems that they may have, any new injuries that they had related to the traumatic brain injury, maybe an orthopedic problem or something else that occurred that is complicating the overall traumatic brain injury picture. And history of prior brain injuries are very relevant as well. Also, comorbid history of substance abuse, which is very common in traumatic brain injury. That's important to know about, and important to know, is this substance abuse continuing now that they've had a traumatic brain injury? So differential diagnosis. So this person, again, comes into the office, this whole list of different problems or complaints that they're having. I like to try and go through and first elicit all the different problems that the patient may be complaining of, and then just try and come up with a differential diagnosis. What other things may be causing these symptoms? What other problems might they be having that I could address? Once I've addressed those other problems, then we can focus more on the brain injury itself and what lingering things may be present there. So cervical acceleration, deceleration related injuries, or whiplash. Patients with whiplash, and this often you have a patient who had a motor vehicle accident, and they have some neck pain. They have headaches, they have dizziness, they have some visual disturbance. They may feel like their balance is impaired. And they may also complain of some cognitive dysfunction. And is that really related to the brain injury, or is that related to this whiplash neck type injury? It's very difficult for any of us to go through our daily lives, go to work if we're having horrible neck pain with headaches. Very difficult to tell. So a good neck exam is very important, trying to address that underlying pain and problems. Oftentimes they make their neck feel better. A lot of the other symptoms they're having will get better too. So depression. So we talked about very common after traumatic brain injury. Up to 50% of people may have depression after this, and it's commonly related to the TBI itself. There are actually alterations in brain chemistry associated with the traumatic brain injury that may make people more predisposed to be depressed. Additionally, all of these changes in their lives may contribute to this as well. I can't go back to work. I might lose my job. Everything else that has been going on that's compounding this particular situation. Depression symptoms, decreased cognition, decreased attention, fatigue, sleep impairment. Again, the same type of symptoms that we may see with traumatic brain injury. And it's hard to tell, is this from the depression or is this from the traumatic brain injury itself? Medications or substance abuse. So a lot of patients may, let's say, motor vehicle accident. They may have sustained a head injury, they may have broken their arm or their leg. They're now on narcotic pain medications. Obviously, those narcotic pain medications can impair their cognition, can impair the way this person is thinking. Any other medications that they may have been started Let's say they had seizures or are on a seizure prophylactic medication. That can impair the way someone is thinking. So decreased cognition, decreased attention, fatigue, sleep impairment, again, all could be related to medicines that they're on. It's important to look at those medicines and try and see which medicines do I need, which medicines don't I, what can we eliminate or change to try and help with some of that. Sleep apnea. Oftentimes, a lot of people may have sleep apnea. It's very common in the general population. Symptoms of sleep apnea can be fatigue during the day, memory impairment. Lots of symptoms that are very similar to someone who has a TBI. So to make sure that they've been evaluated for sleep apnea, if there's someone that you suspect may have that problem, and treated for it appropriately. Endocrinopathies, pituitary dysfunction. Someone really has hypothyroidism. This could be related to the traumatic brain injury itself, as it can cause alterations in pituitary function, or they may have had an underlying hypothyroidism that wasn't addressed. Radiculopathies, so again, pain, let's say, radiating down the neck into the hand. Obviously, any one of us, if we had symptoms like that, probably wouldn't be thinking so well, wouldn't be doing that great at work. It would impair all other aspects of our lives, so make sure that we address that and treat it. And post-traumatic stress disorder. Very common, again, particularly in people with traumatic injuries. This was back when I was at JFK, I had a patient who was involved in a train accident. So, the trains out in, around the East Coast. Was involved in a horrific train accident, and this person had horrible PTSD related to this. They couldn't get back on a train again. They'd have nightmares about it. They had a whole host of symptoms that, yes, they had a traumatic brain injury, but the PTSD was definitely compounding that picture and was something that needed to be addressed. And a legal process. Oftentimes people are involved potentially in lawsuits related to these accidents. That process itself can be very stressful to the person, can cause anxiety, depression, a host of other concerns. So general philosophy to the management of traumatic brain injury. So listen to the patient and recognize these symptoms that they're having. Education regarding traumatic brain injury and common symptoms after traumatic brain injury. Some people may come into my office and they'll describe a host of symptoms to me. They may have seen another physician and didn't really get a clear answer as to what was going on. And they just, think, doctor, I'm crazy. I have all these symptoms. No one believes me. My head CT was normal. No one can find anything that's wrong with me. Why am I having all these symptoms? And just recognizing and educating them about common symptoms after traumatic brain injury is enough to help them get on with the things that they need to do in their lives. And then symptom management. Patients who have persistent symptoms need to be addressed. That's when we go to treatment of this, if these symptoms persist. So this is just a fact sheet about concussion and brain injury that can be helpful to hand out to patients just so they're aware of the common symptoms to see and that these things they're not crazy, they're real, they are having these problems and they're legitimate. So as you talked about, just members that may be involved in the rehabilitation of a traumatic brain injury. There are an extensive number of people that can be involved in this and may be beneficial to a patient's care. So physical medicine rehab doctors, neurologists, physical therapists, occupational therapists, speech-language pathologists, neuropsychologists or psychologists, recreational therapists, vocational counselors, nurses, social workers, case managers, the list goes on and on and on. Other physicians that may be beneficial to their care, psychiatrists, ENT physicians, neurosurgeons, depending on what sort of conditions or problems that the patient is having. So rehabilitation and treatment goals. Obviously, alleviate symptoms. That's where I like to go first. What are the symptoms that you're having today? What's bothering you? What is the biggest symptom to you? And I try and start there and see if I can help with that particular one first. Focus on restoring their function to the best extent possible. Some people may not be able to solve all of your problems or fix all of your symptoms, but what can we do to improve your quality of life and make you as functional as we possibly can? And provide compensatory strategies when appropriate to help them deal with these things. So if we've identified you have these persistent problems, they've been there long standing, what can we do so that you can work around those problems to function better in your life? So some of the most common things that I'll end up seeing, again, headache. So this is the most common acute and chronic complaint following a traumatic brain injury. It's more common actually in patients who have what are considered mild injuries than it is in more severe injuries for whatever reason. And this is often secondary to actually some cervical injury as opposed to the mild TBI itself. And that's somewhere where I like to look first is to examine the neck. See if this is related to the neck because there are things that I can do to help with that particular symptoms. And oftentimes these patients may have seen a physician, they were started on a medication to treat headaches, they didn't get any better because the headache isn't really from the head itself, it's from the neck. So causes of headaches, again, musculoskeletal, tension, nerve injuries, neurovascular, more migrainous headaches, or sympathetic changes. So this is one thing, a common cause that I see of headaches in my clinics is going to be occipital neuralgia. This is an inflammation or irritation of one of the nerves that comes out of the back of the neck, and that nerve actually travels up the back of the neck, around the front of the scalp, and provides sensation along these areas. Patients may complain of horrible pain that radiates up from the back of their head to the front of their face. They may complain of pain behind their eyes. It may be burning, zapping, shooting. It may keep them awake at night. It may be aggravated every time they move their head. And if that's not treated appropriately, this can be a chronic problem for people. So oftentimes, as simple as just palpating along the back of the patient's head, locating where that nerve is, pressing right over that nerve causes this electric-like pain sensation to shoot across the scalp. Once you identify that this problem is there are many treatments for it. One can be simple rest, therapy, NSAIDs, nerve-related pain medications. Sometimes we use seizure medications like gabapentin or Neurontin to help settle that nerve inflammation down. And oftentimes this is very responsive to a simple corticosteroid injection right along where that nerve travels. That little bit of anti-inflammatory medication helps settle the nerve down and calm their symptoms down. If this is controlled, obviously all these other symptoms they may be having and related to it may get better. So someone who says, I can't concentrate at work, I can't do my job, I'm having memory impairment. It's difficult for any of us to do these tasks when you're having a horrible headache all the time. Dizziness. So there are many causes of dizziness, very common after traumatic brain injury. The most common one I probably see is related to what's called benign paroxysmal positional vertigo. And we'll talk about that a little bit more. There are some other causes of dizziness, problems that are more central in origin that can be a little bit more difficult to treat. Some people with cervical or neck-related problems may actually have dizziness as well. And rarely, post-traumatic migraines or maybe epilepsy, seizures could cause some dizziness or sensations associated with that. So benign paroxysmal positional vertigo. Simply, all that this is there are these little tiny crystals, and they're located in a particular, let's see if I can get this pointer to work here. Yeah. Nope. Okay. They're normally located right here in the utricle, in this particular location. When you have a trauma, any kind of disruption, those little crystals that normally tell our body where we are in space, our position in space, may get disrupted. And those little crystals may come out of this space and start floating around into other areas where they're not supposed to be. Those crystals being in those other areas can cause the patient to feel extremely unsteady, dizzy, feel like the world is spinning around them. I don't know if anyone in this room has had vertigo before, but it's a very uncomfortable, horrible sensation to have. Patient will complain that they notice this dizziness when they get out of bed in the morning, when they change positions, when I bend down to tie my shoes. That's when they feel the sensation come on. They may fall in association with this. They may have some nausea or even potentially vomiting. They'll notice also that when they sit really still and don't move, usually the symptoms go away. So this is where I like to start with dizziness, is how do we address this particular issue? So it's usually self-limiting, and this is something that just reassurance that usually this will go away on its own. If it doesn't, there's some other things we can do for this, and there's vestibular rehab or vestibular habituation, and that's in therapy where they actually go through a series of maneuvers to try and get these crystals that are now out of place to go back to where they're supposed to be. Usually with time in these maneuvers, things get better for the patient. If they don't, if they persist, if it's a chronic issue, there are some other drugs that you can potentially use to help control the dizziness. I also like to have my patients see an ear, nose, and throat physician for a more thorough evaluation to make sure there's nothing else that could be potentially causing this. I have a patient right now who had a cervical spine injury, who had surgery on their neck, and obviously right now they're not going to be able to go through those maneuvers of putting your head in different positions. So in the interim, I put them on a medication to help control some of the dizziness that they're having. So cognitive or linguistics disorders. So often see problems with short-term memory impairment, processing speed, language impairments, attention impairment, concentration impairment. And sometimes it's very hard to say which type of process does this patient have. All of these things can impact one another. If you can't pay attention, I'm losing my pointer again. All right. If you can't pay attention, it's very difficult for you to form memories. Patients may complain, I don't remember things, but is that because their memory is actually impaired, or is that because they simply cannot pay attention or focus on the information that's being presented to them? So if patient has these persistent memory type impairments, or symptoms of memory impairment, that's when I like to have them have a neuropsychological evaluation done. That will give us more extensive, sorry? Oh, okay. That'll give us more extensive information about where the underlying problem might be. This information then can help us develop different treatment strategies to cope with those particular problems, okay? When I have this neuropsychological testing done, I usually like to wait a little bit of time. I want to make sure that the patient is stable. I also want to make sure that I've addressed all of those other symptoms that they might be having that could impair their performance on this test. If someone has a horrible headache, neck pain, and dizziness, and then I ask them to take a 4-hour-long series of tests, they may not do very well, and it may not give me the best information. So I like to address the other issues first, and then move on to address these particular symptoms that they're having, okay? Depending on the results of this testing, that can guide us in terms of treatment and potentially certain medication management, things like stimulants to help with their attention and focus, or potentially even using medications like Aricept. They're used potentially for dementia, but you use them off-label sometimes in traumatic brain injury. So cognitive remediation, or cognitive rehab, sorry there. All right, so this is where we develop strategies to help patients compensate for these areas of weakness, again, that we've identified. And that neuropsychological testing, again, helps guide that particular treatment plan of letting patients or guiding patients into how they deal with their particular symptoms. It can definitely be beneficial. Focus on activities of daily living, family relations, return to recreational activities, and work re-entry, ideally. So visual disorders, again, common problem after traumatic brain injury. Patients may complain of double vision. They may complain of sensitivity to light. They may complain of difficulty focusing, blurred vision, a multitude of problems. This may be associated with dizziness, and sometimes takes a little bit of time to sort out. Oftentimes I will refer patients to an ophthalmologist to have this evaluated further, make sure there are no types of underlying problems going on with the eyes. Obviously, someone who had glasses, make sure that that has been addressed. If these symptoms don't improve, I like to send people to visual rehab, where they'll focus on actually engaging the eye musculature, trying to compensate for the issues that they're having. And once in a while, someone may benefit from actually called prism glasses, where they have actual little changes in the lenses that help adjust for some of these changes in their vision. Usually only go that route if this has become a permanent problem, and they may need these prism glasses long term. Insomnia. Again, an extremely common complaint after traumatic brain injury, patients who can't sleep. Getting patients to sleep better will improve their function overall. None of us do well when we don't have a good night's of sleep. So one, I like to look at all the other factors that may be contributing to this poor sleep, such as pain, neck pain, headaches, other things that may be associated with insomnia itself, depression. People may not sleep well, anxiety, this PTSD, a patient that I had having nightmares every night about this train accident. Obviously, they're not going to sleep very well. And other things, again, such as sleep apnea. If this person, if we suspect in any way this person may have underlying sleep apnea, to have them evaluated for that so they can get appropriate treatment. So treatment for insomnia itself, sleep hygiene, education about this, no using screens at night, laying in bed, playing on your cell phone, doing work while you're in bed, just trying to create a space where this is the time I go to sleep. These are, my room is for sleeping only. I don't do all these other activities while I'm in bed. Sleep aid medications, or some different medications that we can use to help someone with sleep. Usually I like to start out with something as simple as over-the-counter melatonin. A lot of people find that to be effective. It doesn't usually have a lot of bad side effects for them. And obviously treating all the other conditions that are going on that could contribute to this sleep impairment. Behavioral issues. These can be a little bit more challenging to treat and often present after traumatic brain injury. So patients most commonly will have fluctuations in their emotions. They may notice that I get really, really angry about things that normally wouldn't have bothered me. I'm having emotional outbursts. I'm yelling at my spouse. I'm getting really frustrated with things at work. I'm crying. I'm depressed, and I don't know why. Treatment regarding this. So counseling, psychology, support, having discussions with the family and the patient to try and figure out what are causing these things. Counseling for the patient, treating them, when I feel that this sense is coming on, when I feel that I'm getting angry, what can I do to keep these situations from happening? What can I do now? I'm just going to walk away. I'm going to count to 10, certain strategies they can come up with to help cope with these particular emotions that they're feeling. And obviously medications, treatment of depression, treatment of the underlying anxiety. Selective serotonin reuptake inhibitors can be very beneficial to this. There are a host of medications that may be beneficial to this. I usually like to manage this on my own. Once in a while, if things are complicated, I may have a psychiatrist also look at the patient to make sure that they're on appropriate medications to help them cope with these particular symptoms. And this is just a little thing about some promising research, new research that's coming out right now. This is the TRACK TBI study, or the Transforming Research and Clinical Knowledge in Traumatic Brain Injury. And this is actually ongoing currently. It's out of UCSF. They're attempting to recruit 3,000 subjects into this study with traumatic brain injury. And the goals of this study are actually to collect lots and lots and lots of data on these particular patients and put this into a large database. And they want to look at biomarkers, blood, imaging tests, CTs, MRIs, detailed information about clinical outcomes in hopes that we can actually improve this TBI classification a little bit. So maybe we're not just saying mild, moderate, or severe. Maybe we can categorize patients based off location of injury. These patients have these particular neuroimaging findings, and maybe with that, we can find drugs that may be more effective. Because right now, a lot of the studies that are out there, again, we have apples and oranges that are together. They're all lumped into one category, and what might work well for one person doesn't necessarily work well in the study overall. So again, the expected outcome for this is to identify these new diagnostic and prognostic markers and refine outcome assessments, which would hopefully overall lead to successful treatment in clinical trials. So that's really all I have right now. I don't know if you have time for questions or hold them for the end. Okay. Does anybody have any questions about anything right now? I know that was kind of a whirlwind of information. Obviously cannot cover the treatment of TBI completely in one 30-minute talk, but anyone? Oh, yes.
When you work with TBI patients and providing care,
yeah,
as providers, sometimes we look at payer sources and willingness, covered benefits, and that sort of thing. And it seems like, other than maybe no-fault auto insurance, and a lot of the payers don't recognize it as they should, as far as testing, the post-care once diagnosis has been determined. What is your experience with that?
Well, my experience where I did fellowship at was in New Jersey, and in New Jersey we actually had a cap on auto benefits, so I didn't even have that kind of luxury of having auto to help with this. So here, in my experience here, I've had so many more resources than what I had previously out in New Jersey. I haven't personally had a lot of difficulty getting things covered, provided I document well why I want these particular tests or particular needs. I don't know, Dr. Mucky, if you've had a different experience regarding that. Yeah, if I, a good justification for why I'm getting this particular test or why I want this particular medication or whatnot, it usually seems to be covered for me.
Another question.
Yeah.
We're pleased to say that we have a couple of NFL players here today, and they're going to do a Q&A thing in a little bit after we get through asking our questions. But are young children more susceptible to an injury, the same type of blow, let's say? Are they more susceptible to an injury, a lifelong injury, or is there recovery time for a younger, like if you break a bone and you're young, they say that you heal faster. Mm-hmm. Does that work with the brain?
Well, there are definitely differences because the brain is still developing as a child. So that direct injury or insult on a developing brain is definitely different than an insult on an adult brain that's, fully formed. It also may be difficult in someone who is a child who sustained an injury. They may have issues with learning information or retaining information, as opposed to an adult who may already have an established career or an established education, or all this information that's already been stored that they have to rely on. That sometimes it's more difficult for children actually to progress to the same level as an adult would. I don't know, again, Dr. Mucky, if you had any other suggestions or thoughts on that?
I mean, a lot of it also depends on at what age.
Yeah.
Also, whether there's recurrent injury. Unfortunately, there are those pediatric patients that have 1, 2, 3 injuries, and it never goes down to baseline. Basically, it's an additive effect every time you have an injury. Also depends on the area of injury. Be it frontal, forehead, back, or is this something like what we call hypoxia, lack of oxygen. So those are variables that will determine recovery and age.
Yeah.
Just like anyone else.
Yeah.
Now, it is true though that pediatric patients, because they're young, they're still developing, they tend to be able to regain a lot quicker some of the loss
Sure.
of function than adults do.
Sure.
As we all get older, there's more of a delay in terms of recovery.
Anybody else? Yep.
My husband had a mild traumatic brain injury in 1991,
Mm-hmm.
and we were told then that as he aged, we might see kind of an increase in his headaches, his cognition, his attention, and I'm seeing that now.
Yeah.
So that is something that's really legitimate.
That definitely can occur, yes. Yeah.
He was unconscious about a half hour.
Okay.
Then he went on for months before he was able to go back to work because he lost another job.
Mhm.
Because of his depression, his headaches, his dizziness, all of that. And now I see the cognition especially
Right.
in his memory at this point.
Yeah.
Because he's over 80 now.
Okay.
He's sharp as a tack until about maybe years ago, not really.
You seeing that changes. And yes, that definitely is something that can happen. It's important that he's evaluated to make sure that there isn't anything else going on, that there's nothing else that's contributing to this. It's definitely important. But yes, you can see that happen, unfortunately.